Thank you very much for that informative discussion. I'm thrilled to introduce Rachel Byrne. She has worked with the NEON Collaborative for a few years now and has been very helpful in guiding us in a very positive direction. Rachel is the executive director at the Cerebral Palsy Foundation, and she's been working in the field of pediatric rehabilitation and cerebral palsy research for the past 14 years. She has a background in physical therapy with a particular interest in neuroplasticity and motor learning. Her early career as a clinician delivering physical therapy services in schools, hospitals, and private practice is underpinned by her research interests focused on knowledge translation and the impact on a person's ability to participate in the community across the lifespan. At the CP Foundation, she's continued her research interest in evidence-based practice, knowledge translation, early detection, and interventions across the lifespan in population studies for CP. She's been instrumental in developing the Just Say Hi inclusion curriculum, and that is now being taught nationally. And over the last 12 years, she's given several presentations at international conferences and has managed large multi-site research projects. And with that, I have the pleasure to introduce Rachel Byrne.
Thank you so much, Yvette, and thank you everyone, obviously, for having me here today. I will just, and I hope everyone can hear me well, and I'll just share my screen at the moment. And did that work? Just checking that that has actually popped up for everybody. So, you know, one of the big things that I've been asked to talk about today is early intervention for cerebral palsy. And I think we can all sort of start on, well, what happens before intervention is early detection. So why should we focus on trying to do these things as early as possible? When we're thinking about cerebral palsy, it is the most common lifelong motor disability affecting over 17 million people worldwide. So it's about 3 to 4 per 1,000 births impacted by cerebral palsy, and there's over 1 million people here in the US. And cerebral palsy is an injury to the developing brain that interferes with movement and coordination. So when we're thinking about a diagnosis, it can and it should happen as early as possible. So there were guidelines for early detection that were done by an international working group in 2017. And what these are based on is a neurological exam, motor function examination, neuroimaging, clinical history, and biomarkers. And the great news is that probably in the last 5 years, there's been a huge shift. The average age of diagnosis previous to these guidelines was actually around after 2 years of age, really not just in the US, but across the world. And now in the US, across our network, we've been able to get it down to 9 months of age. And there's definitely other initiatives happening worldwide to do the same. So if we're thinking about, you know, the neurodevelopmental problems, they start in infancy. And this is why early detection intervention is so important, because obviously the neonatal brain, you have things like injury, potentially prematurity. Then you have the things of plasticity and growth that is happening at the same time. And these impact all the body systems, including the sensory systems, the motor systems, and have a lot of things to do with behavior, communication, cognition, and obviously motor outcomes. And the common questions that we get, particularly around cerebral palsy and from parents and family members, is initially, you know, what's wrong with my baby? I'm noticing that they are doing things differently, potentially than a sibling or than other children in my motor group. And the next question we get is, what is cerebral palsy? And I think it's one of these things that we really need to increase awareness of and understanding. The next is usually, what is my baby's prognosis and what can we expect? And the great news is, with the increase in research that's been happening worldwide, we've really been able to now predict some of those things and be able to actually answer those questions. The other big question that we get from parents is, what interventions offer the most evidence-supported results? And that's what we're going to be talking about today. And then what online resources are current. So what we do know is that interventions can change trajectories. So if we're thinking about brain plasticity, The brain, as it's developing, forms new connections in neurons and all the brain systems, and it develops new functionality. And really, the peak is in the first 3 years of life. So if we have a delayed diagnosis and delayed specific interventions, we're losing the opportunity to make big change in that sort of time period. And I think the important thing to remember is this sort of opportunity for recovery is also vulnerability. So if we think about the principles of neuroplasticity and how we're really going to be impacting the brain, it really involves self-initiated movement. So what we mean by that is that the child or the baby themselves is really involved in the activity. It needs to have mental and physical effort. It can't be a passive piece. The child needs to be engaged in what's going on. The intensity of training, that's really important to think about, well, how often are these interventions taking place? What you don't want it to be is rote. So for example, when we all learn an activity, sometimes it just becomes second nature and that we can do it over and over again and we don't really have to think about it anymore. But when we're learning a new skill, we usually have to break things down and think about very specifically how we're going to achieve that. So when we're thinking about early intervention, while it's great that a skill can be achieved, we don't want that to just be the only thing that we practice. There needs to be variability. It really needs to be meaningful to the participants. So when we're thinking about infants, what are meaningful activities to them? Meaningful activities to them are engaging with their parents and their family, having that interaction that you see. And, I think the important thing then to wrap all this up is that neuroplasticity really depends on age, intensity, specificity, and salience. So James Heckman, which is the Nobel laureate in economics, has really shown that the programs that happen before 3 years of age actually lead to the greatest outcomes and the trajectories longer term. So you get this really increased rate of return on investment. So we know that we need to, as much as possible, do these programs as early as possible. So the wonderful thing when it comes to early interventions is that the actual International Clinical Practice Guidelines for cerebral palsy were published last year. And this is a really big step forward for the field because it's a summary of what are all the interventions that have been researched so far and what's the best evidence around them. And when we think about the breakdown of what it is, there's 3 categories. There's skills development, complication prevention, and parent support. And then they're broken down further into motor, cognition, communication, eating and drinking, vision, sleep, tone, musculoskeletal, mental health, and parenting. So on this first slide, it shows skills development. So when we're thinking about the 4 major areas that infants, develop skills, it's in motor development, cognition, communication, eating, and drinking. And what they've been able to do is actually break it down into then what potential type of cerebral palsy that infant may have. So whether it be bilateral cerebral palsy, so affecting both sides of the body, or unilateral cerebral palsy affecting one side of the body. So those that are in green are actually those that have good evidence. So you'll see throughout this, there's a lot of work still to be done because there's a lot of unknowns. But what it's showing is that intervention should be CP specific. So while we know that it's wonderful to do early intervention programs, if we really want to impact skills development specifically for cerebral palsy, we need to think about CP specific activities. We need to make sure that they're task-specific motor training. Other things that have been shown for unilateral cerebral palsy, and I'll actually give you examples of programs coming up in the presentation, are constraint-induced movement therapy or bimanual therapy, and for cognition, cognitive interventions as well. So the things here in red are things that we probably shouldn't really be continuing or thinking about, well, what is the purpose of these and why are we doing them? So passive movement, when we're thinking about if we want to really impact neuroplasticity, passive movement is not going to lead to those changes that we're looking for. And then again, this generic development education alone will not do it. So while that can definitely have benefits for other areas of childhood development, if we're really specifically looking for motor improvement on cognition improvement, these generic pieces will not do it. So for communication, you'll see that things are now in yellow. So yellow means that there is levels of evidence, but maybe we need to do more, or there's still uncertainty around the specifics of these interventions. So if we're looking at pre-verbal skills, you're looking at face-to-face nurturing interactions with vocalizations, joint attentions, and reciprocal interactions. There's also something called the Hannon program, which is a communication-based program for early infants. Then if we're thinking about eating and drinking, and particularly thinking about dysphagia, if a child has issues in there, looking at, okay, well, soft food actually can lead to better outcomes when it comes to eating and drinking, and semi-recline and upright positioning. Okay, so complication prevention. So this is something that sort of really gets asked, we get asked a lot about. So what about the comorbidities that we see with cerebral palsy? So things like vision and sleep, tone, and then musculoskeletal complications. So as you can see, currently, there's nothing really in green in these areas. There are some red, so they're good to sort of think about when you think about, all right, well, what are the things that we should be doing or maybe shouldn't be doing? So there are things for strabismus, cerebral visual impairments. There's things for sleep. And good sleep hygiene is really important when we're thinking about, all right, if we want to really impact neuroplasticity, sleep and recovery for an infant is so important. So the thing I think all of us would probably agree upon is stimulation before bedtime is not helpful to sleep. I probably need to practice that more myself, as far as, making sure there's no screens and all those things that we now know about what helps with creating good sleep. The other thing to sort of look at down here is if you're thinking about sleep disturbances, sleep systems and complementary and alternative medicines at this stage haven't shown to improve sleep disturbance. So tone. So when we think about tone and hypertonia, a lot of those things currently happen probably later on in a child's sort of development, but they are a very comprehensive management. So tone management can include everything from pharmacological management, from thinking about orthotics, thinking about exercises, but what it needs to be, it can't be just one part of that. It really needs to be a comprehensive system. And then if we're thinking about musculoskeletal, so those children that are non-weight bearing, so standing equipment for positioning is sort of in that yellow area, and the risk of ankle contracture, so you've got ankle foot orthosis. The really important piece that was also done as part of these international clinical guidelines was parent support. So knowing that really that the parent is the center of the child's universe, right? So we know that without really solid parent support, having good infant interventions is almost going to be impossible. So when we're thinking about parent support, looking at the parent's mental health, so how to actually manage stress, anxiety, depression, and trauma that might come from that, and then parenting actual interventions themselves. So how are they going to get that bond with their child? And for those babies that are born premature and have time in the NICU, the kangaroo care in the NICU obviously fits under that. Music therapy in the NICU does as well, and attachment support and coaching. So now to go through some example interventions, and some of these interventions are still probably more in the research phases of interventions. Some of them are still actually getting done as randomized controlled trials across the country, but I just wanted to give you an idea of what they look like. So just to repeat, the commonalities across all of these are the intensity of training. We know that there needs to be a certain level to be effective. It needs to be active movement. The motivational strategies need to be child-friendly. We need to include parenting interventions, and we need to focus on functional goals defined with both children and parents. So if we're thinking about interventions to improve cognitive outcomes, so the goals for these are usually to enhance infant development by providing or directing physical or other therapies, reducing infant stress and environmental enrichment, and helping parents read and respond to infant cues, and helping parents also support the adjustment and mental health issues that may come up. So for cognitive, for interventions that will improve cognitive outcomes, some of them start within the NICU, and others will be early after discharge. So not specific to CP, though this population is at risk for motor impairment. So there are documented positive effects on cognitive and motor outcomes during infancy, and so there's something that we really need to develop in a stronger capacity. And the programs that were most effective are those that address both the parenting and infant development simultaneously, because they're far more effective than just addressing one alone. So an example of thinking along these lines, thinking about parenting stress and parenting itself, is the baby triple P for preterm infants. So this was a research study done in 2019, and it was 384 infants who were gestational age under 32 weeks, and they were randomized to triple P or usual care. And so the focus on teaching parents coping skills, parenting strategies, and really thinking about, well, how do we deliver that? So again, thinking about, well, what's the dose that's needed? So this was 4 sessions in the hospital and 4 home phone sessions. So a lot of these interventions you'll start to see have this combination between what is a hospital setting and what's the home setting. And what they found was that triple P families had higher cognitive and motor scores at 2 years on the Bailey. So sort of switching gears now to thinking about motor enrichment and motor interventions. So the GAME trial, which the protocol has been published, but we're still waiting for more data of that to be published, that happened in Australia or still happening in Australia, is the GOALS activity motor enrichment. So this was 30 infants in Sydney at risk of CP, and they really began at 3 to 4 months. And GAME included home motor learning activities, parent coaching, environmental enrichment, home visits. And what they were able to reveal was at 12 months, they had higher scores on the motor test and the Bailey-3 and the cognitive scale. But again, you're going to be seeing these sort of commonalities across all these interventions when it comes to at home, parent coaching, environmental enrichment. So LEAP CP, so this is learning through everyday activities with parents. So this is actually done in countries, and this was actually done in India, so in low middle income in countries, and it was 142 infants, 12 to 40 weeks at high risk of CP, and it included coaching by community disability workers of caregiver sessions 5 days a week, and they were activities based on games, so what you just saw previously, plus 15 hours of direct therapy. And their primary outcomes that showed a difference was the mobility on the Pedicat and cognitive outcomes on the Bailey. So this study is also ongoing, but I think what it really shows is actually when you're thinking about different environments on where you can actually do these interventions and who is facilitating the interventions, you've got everything from, yes, highly trained physical therapists and physicians to more community health workers, and then families as well doing these interventions. So then for those children with unilateral cerebral palsy or who have asymmetry, so where we do know that in the green light section was constraint-induced movement therapy. So baby CIMT, this was an intervention that was for children with cerebral palsy between 3 to 8 months of age. And they had a baby CMIT group. The control group was 13 babies that did baby massage. It was 2 6-week interventions with a 6-week pause in the middle. And they did 30 minutes per day times 6 days. And it was a glove constraint. So it was a soft constraint. And parents were coached during play activities. And so what they found, and you can see on these graphs, is that baby CMIT, both on the high and the AHA, showed a significant difference compared to baby massage. And they had, there was no differences at baseline. And what this is starting to do is actually address the mildest type of cerebral palsy. So I think it's really interesting when we go back to going, all right, what are the specific interventions that we need to do for each child? We need to think about, okay, well, what is the motor type that this child has, but also what potentially level of severity do they have as well? So another constraint-induced movement therapy is Apple's Telly, and this is actually a randomized control trial that's funded by the NIH that is currently happening actually across our CPF network. And it is 5 weekly telehealth sessions of a therapist and demonstrated tasks. The infants themselves wear a soft constraint, so it's a little mitt on their good hand for 6 hours per day. And it really is a parent-focused encouragement of using their affected arm as much as possible in play-based activities throughout the day. And as the infant experiences success, those activities become more complicated. So if we remember going back to the original piece, is that these activities need to have variability. Once success happens, we need to sort of go on to the next stage. And when the mitten isn't getting worn, then bimanual therapy is really encouraged. So activities that require both hands as much as possible. The commonality here, again, is that there's a parent support piece that goes in line with this, and that is the positive parenting from Triple P. So, going to the sort of lower limb right now, there's a lot of work currently happening around selective motor control. So when we're thinking about selective motor control, it's the ability to really isolate different muscles to either go, okay, I'm just going to move my ankle, I'm just going to move my knee, or I'm just going to move my hip. And really, when you think of kicking, it's contingent of having selective motor control. And what we know is that babies and infants with cerebral palsy don't have that ability. And that actually starts very early on. And I think this is why when we're thinking about early interventions, kicking for the lower limb is sort of something that's really getting studied currently. And this video here will just show you an example. So this child has hemiplegia. And as you can see, in the initial kick, he went to go kick the ball, but what happened is he didn't have the selectivity to use the control at the knee and ankle. And actually what he did that sort of gross movement where he flexed his hip. And obviously that doesn't lead to a successful kick. Just watch that again. So things that can be done, thinking about selective motor control in infants, obviously mobiles. A lot of the time mobiles are set up to encourage upper limb mobility and function, but thinking about what that could look like for the legs. There's the little socks that have, wonderful things for the babies to grab their feet. But yeah, really thinking about, well, how can we encourage that as early as possible? The other thing to think about really is the role of mobility devices. So for those children that might have a more severe type of cerebral palsy, ideally what we want these mobility devices to do is to manipulate the environment per se, not the child. So it's meant to make the task easier and achievable, but the child is still meant to be active and they're still meant to be engaged in the activity. So there's quite a few of these currently underway being investigated or actually available. So there's reduced gravity or strength requirements. So this is sort of currently getting studied right now to go, okay, if we can take some of the effects of gravity away from these children, so similar, I suppose, to what you might see in hydrotherapy or something like that, do they actually have the ability to get some of this movement happening? Increased motivation. So mobility devices, as I said, with kicking, if you can create a mobile that is interesting, it actually increases the motivation for the infant to do it. Increased practice. So an infant treadmill and sometimes other passive mobility devices could play a role. And then strategies. So for those of you that don't know about Go Baby Go, and that's led by Cole Galloway, that is really looking at adapting toys, so toy cars that are available on the market at sort of any, one of the big retailers, and going, okay, let's adapt those so these babies can feel what it's like to initiate movement and feel that active movement. Thinking about, all right, what are the early interventions that are currently happening? How can we think about developing our own, and what are the principles that we really need to consider when we're developing any early interventions? Are the 5 E words. So this was published by Diane Damiano in 2020. And again, it's just reiterating the majority of things that I've already said. So early, so as young as possible and as often. So every day. Active engagement is essential to learning. They need to do self-exploration exploration and be in an enriched environment, and coach parents and caregivers to integrate these activities. And I think this is important, that these aren't, all the things that I've mentioned can be done within the home. They're not done with sort of intense hospital-based sessions. So if we think about the early, the why, and the when, I've covered it a little bit, but really it is just as the timing of the brain injury affects outcomes, the timing of intervention does as well. And I think when we're thinking about the window of recovery, you know, it's really important to remember that the first 3 years of life are the most opportunistic time for neuroplasticity. And I think the thing to look at, and studies have shown, is that failing to provide specific inputs at specific times can lead to permanent loss of capability. So thinking about, all right, how can we build that up? And then for motor function, there's multiple regions that are involved. And I think this is also important, because when you're thinking about potentially other outcomes that happen, cerebral palsy is impacting, as you saw, all the different body systems. So you're thinking about multiple areas of the brain. So you want to optimize the neuroplasticity as much as possible. But, you know, we always know that there's challenges to starting early. And I think number one, it requires an early diagnosis to know who needs it. So going back to, well, how do you do an early diagnosis? Following those guidelines, implementing those in your clinics. And if your families, you know, advocating for that to happen. You know, the tricky thing is what we see is that babies have fewer motor capabilities in the first 6 months of life. You know, as humans, we don't automatically get up and start to walk. You know, it takes us a long time to actually develop these motor skills. And the catch-22 here is, well, how do we help them practice a skill that they cannot do? And this is where these engaging activities and parent interventions and potentially some sort of assistive pieces can help. But that's where these novel strategies really come into play. So I've touched on it already, but engagement. So infants must be attending to and enjoying what they are doing. So it needs to be active, and how they enjoy these activities is really because of who they're participating in these activities with. So when you think about babies love, enjoy making movements and noises. So it's interacting with them, smiling or talking and making movements and noises with them. You know, it's a playing with a toy that they love, or trying to move or change positions to accomplish a goal. And I think the really important thing here is making, you know, we call it the just right challenge. So making the task not too difficult, not too easily, because otherwise children really rapidly lose interest. Exploration. And this really should be self-initiated and self-motivated movement. So, you know, they love to problem solve and learn where they can go in their environment. And the really important thing here is that this exploration actually then helps with sensory feedback and helping develop the sensory system as well. And this is why external stimulus, too much of that, can be detrimental. You know, I think when you're thinking about self-initiated and self-motivated movement, yes, there's actually the ability to do it without, say, a mobility device. But sometimes babies do need a mobility device to do that. You just don't want to have too much external stimulus so that they don't actually have that sensory feedback. An enriched environment. So we know that movement is a major way that infants engage with the world. So motor experiences affect all parts of development and are a key component of environmental enrichment. There is extensive research currently in the animal literature on making environments visually, cognitive stimulating, and, you know, challenging for motor development. And we need to make sure that play environments are varied and progressed over time. And there's lots of different things here. And I think it's really an interesting area of study. And we will be getting, I think, more examples on, you know, how do we really utilize the environment and make it the best possible. So this is from Kathy Morgan in 2013. And so although there are no agreed parameters for enrichment, we do know from animal studies that conditions typically include high levels of complexity and variability, with arrangement of toys, platforms and tunnels changed every few days to promote motor learning and memory. You know, researchers have postulated that is the voluntary and challenge aspect of these environments that are crucial. So, and the big thing is that animals, children, are not forced to perform activities. Rather their engagement with the environment is active and playful, and the motor opportunities are critical for their success factor. So every day, and this is where parents really come into play, because otherwise we would find that we would have infants and babies, 24 hours a day in hospitals and in clinics, and that's just not feasible. Nor would it be appropriate, right? The family is the center component for children. And while we don't have precise dosing at the moment for some of these activities, we know that 1 hour per week is not enough. And so thinking about how to include this as everyday activity is so important. And again, parents have the greatest impact on development, but it's really important that this should not be a burden on caregivers. So how do we actually include this as everyday activity that isn't an add-on to all the other things that are already required? And that's super important, and both from a research perspective, because sometimes research studies can be so well designed that they're not practical and they'll never actually be able to be implemented in clinical care. And then other times, the recommendations that we put forward are too overwhelming for a family, or again, not achievable. And that's actually going to have the opposite effect to what you're trying to achieve. And infants themselves, they have emotions, they have feelings, and they may be tired, or they may be grumpy, they may be hungry. So it's really important to respond to infants and have them dictate the dose. So the challenge. So the big thing is what to do before functional movement emerges. So you can practice anti-gravity control on the tummy and upright. You can provide some supports, but thinking about what is your specific goal. Encourage movements. The amount can either increase the amplitude of what they can do, and you can do that with a variety of ways in music, water, and toys. And thinking about putting toys in or on hands, and as I mentioned before, jingle socks if we're thinking about selective motor control. So, in summary, how would you build your own intervention based on what we know? So you need to make it functional and meaningful, make practice intense and structured. You need to make sure it has training specificity to your specific goals and the motor type that the child and the infant has. You need to make sure that you're balancing activity across body systems and limbs. And when you're thinking about cerebral palsy, and that does affect all different components of the brain and the competition that you're going to have, it's really important to make sure you've got that variability. Utilize principles of motor learning, so all of the different things that we've just discussed. And most importantly, utilize principles of neuroplasticity. So practice-induced brain changes arising from repetition, increase in movement complexity, motivation, and reward. And of course, we are talking about babies here. We're talking about families, so always make it fun. And for those of you who are physicians and clinicians who are really interested in learning more about cerebral palsy and more about what you can do, we are now in our 5th year of our annual Early Cerebral Palsy Health Summit, which focuses on the implementation for detection, intervention, and implementation. And we would love to invite you to come along. And so you can find out more at cpearlydetection.org. Thank you very much.
Okay, thank you very much, Rachel. That was very nice. So while we're waiting for questions to appear in the chat, let me ask you this question. We tell a lot of families to utilize the resources that they have already in the home, the toys and things like that, to enhance motor function and cognition. And I know that this may vary by age and their developmental level and other comorbidities, but can you give us a sense of, across the age spectrum, infancy, childhood, and young children, what might be the must-haves from your perspective as a physical therapist?
Sure. So I think one of the must-haves and one of the really sort of easy things I think to think about is going, okay, if you've got a child who is potentially in supine on their stomach or on their back and they're more in that lying position, you're thinking about, well, what's going to engage them? If they're really young, you want to make sure that probably objects are black and white and, that they can actually have that visual engagement in what you're doing. A parent's face actually goes a long, long way. And sometimes you don't need to get fancy there. A rattle, as I said, sometimes the socks that have things that a child can play with. But really, when you're thinking about at that young age, it's trying to put them in a variety of positions, whether that be tummy time, with a towel rolled up underneath their chest, and more thinking about, all right, how do I engage with them using music, using those different things. As a child transitions from, say, more doing things on their stomach or on their back to those sort of first things of crawling or pulling up to stand, your sofa. The sofa is an amazing piece for people to play on. You take the pillows off the sofa, and it's probably almost the perfect height for children to pull up on. Pick 5 of their favorite toys and put them on one end to the other. And, just even that idea of moving along the sofa, coming back and forth, those different things. It's a really wonderful piece of equipment, I suppose, that you don't think about as a piece of equipment that you can use in the home. Sometimes it makes the lounge room very messy, but, kids love that. They love to explore and love to do it in those different ways.
Right. Okay. There is, I think this is a statement. I guess they're talking about the Go Baby Go program. I guess it's a mobility device.
So Go Baby. So Go Baby Go, for those, I sort of can talk a little bit more about that. So that's a program that was developed by Cole Galloway, and it's actually available all across the world. And volunteers adapt toy cars or mobility sort of, sometimes electric mobility devices that you would find, as I said, within your major stores. So thinking about a toy car, and they adapt that so it can be operated by a switch, and it then has all the supports for sitting and things like that. Sometimes they'll have head supports, and rather than then getting into, say, an early motorized wheelchair, you've got a child who, if they are struggling to sort of think about, well, how do I move from A to B, or they don't really have the motor ability to move from A to B, this gives them the experience of initiating that movement.
Right. That's good. Good thought. Let's see if there are other questions. There's a question here. What is the infant treadmill?
So infant treadmill and harnesses, these are mainly used within research settings or hospital settings currently. And there's still, I think, a lot of work that needs to be done to work out what's the best way to support a child to practice walking. And so infant treadmills are usually it's more got to do with the harness than quote unquote the treadmill itself. And so it's really supported walking on a treadmill.
Okay. And then someone asked about robots. How about robots?
So, and I don't know whether robots means exoskeletons or robots as in the use of sort of more robotic devices for engagement, but I can sort of talk to both just in case. So when you're thinking about robots, there's actually some wonderful toys that are out there that engage with infants. And actually, Ayana Howard, who is at Ohio State University in the engineering department, has created a wonderful, it's a soft turtle, and the interaction that a child gets when they press on it, it really does interact with them. So when you're thinking about robotics and robotic toys, there's absolutely some that are already on the market and they're readily available. If it's more robots thinking about potentially exoskeletons and orthotics, they're for infants a lot more in their infancy, even for adults, really, to be a practical and more clinical piece. They're mainly still in research. But we do know that activated learning, so for example, the robot or an exoskeleton could help facilitate the movement, and then a child can continue that movement. So you still want it to be as active as possible. Whenever you're thinking about adding any sort of external piece or any sort of external, whether it be a mobility device, you still want to make sure that active movement is occurring.
Okay. So there's a question here. Can you speak to the importance of the specialist or physical therapist's role in empowering caregivers and families with this?
Yeah, absolutely. And I think this is where, when we think about the parenting approaches as part of therapy, that I think we all have a role in doing that. So while you may have a team member that can, help support that, whether it be a social worker or a psychologist, I think as therapists, it is our role a lot of the time to help educate families to be able to set their goals and develop things that work for them. And also identifying sometimes when families need help, because you may be the person that's seeing them more regularly. And so I think absolutely, as far as therapists go, they can play a essential role in referral, but they can also help support families and understand that the parenting approach to all these interventions is almost an essential component.
Mm-hmm. Mm-hmm. Let's see. There's a question here. Is the knowledge about these interventions being dispersed to outpatient and inpatient therapists? Is it common knowledge in the therapy realm that passive movement is not enough?
That's a great question. So as I said, these guidelines got published last year. Talking about passive movement, that has sort of been around in research and conversations, I think, for a while now. Like, I wouldn't say it's, just because of these things that were published last year, but we do know that there is a lag between research and those that are sort of really using evidence-based practice and then what's happening in clinical care. Hence why things like this are really important. But I would hope the majority of the time now in early intervention clinics, both that the passive movement is something that people are understanding isn't necessarily the best for cerebral palsy. Mm-hmm. Mm-hmm. But probably still not happening everywhere. So I think that's the thing. Like, if you see it's not happening everywhere, look at these guidelines. Think about, okay, how can we change our clinical practice? Right. What can we do to implement what is currently the best evidence?
Okay. Dr. Gong is asking, does this recommendation about therapy standardized therapies given from therapists? Is there a plan? I'm not sure I'm clear on the question.
No, either am I.
Alice, can you clarify?
Speak. Can you hear me?
Yes.
I think what I'm getting at is I feel like what therapies, when we recommend, say, physical therapy, it seems like that not all the kids are getting the same thing. And we don't know what the therapists are doing. But now that you've got recommendations, is there a plan to implement what is evidence-based and standardize the therapies that are given, which is a lot of what Dr. Dietrich mentioned about passive movement, instead of, just the massage and the passive movement to get the kid to do more things like, spend more time doing tummy time or getting them on the floor, those kinds of things.
I think obviously whenever we can standardize what we're doing, there's benefits in two ways, right? It makes the clinic and things like that actually run better, but it also means that we know that no child's kind of missing out, because we know, okay, well, this is what happens. So from our perspective across our network, we are absolutely now, we've focused on detection probably for the last 3 years, really honing in on that actually across the country. But interventions now absolutely are a focus of ours to go, okay, how can we implement these? Not necessarily in what I showed with the branded interventions. You don't have to implement GAIN, you don't have to implement LEAP or apples. But what you should be following is the principles of these early interventions and going, okay, as we develop these, are we meeting these 5 principles that sort of were published in that Diane Damiano paper? And I think that's a really important piece to go, okay, it's not necessarily we are going to be able to give you a manual, like some of them actually will come with manuals, but it's more thinking about, all right, how do we implement these 5 pieces in everything that we're doing? Okay. But yeah, agree with you, Alice. The implementation piece of this is really important. But as you can see, those papers were published in 2020 and 2021. So we're still at the early stages, and those that are doing this, I would say, are early adopters of this framework.
Yeah, Roy Hine made a comment that dealing with multiple therapists in multiple community-based agencies is a real challenge to standardization. Just trying to, disseminate it across the board. Yeah,
absolutely. And we are in a process of trying to think about how to do more of those different pieces. As I said, we've now got the conference. We hold trainings all across the country, but yeah, we need to be doing more. I hear you on that one.
Okay, well, thank you so much. We really appreciate it. It's time for our break. We have a short 10-minute break, and we'll return at 3:55. Rachel, thank you very much.
Wonderful. Thank you so much, everybody.
All right, thank you.
Bye.